We did it. So, geez, you want to leave that? Just kidding. Okay, so I'm here to introduce Dr. Omar Martinez. Omar Martinez holds a MPH and JD from Indiana University-Bloomington, as well as a master's degree in clinical research methods from Columbia University Mailman School of Public Health. He completed an NIH T32 postdoctoral research fellowship in behavioral science research and HIV prevention. His research expertise includes substance use, mental illness, and HIV prevention among underserved populations, focusing on syndemic factors and social contexts. He has developed and implemented programs addressing health disparities, such as HoMBReS for Latinx heterosexual individuals, and Connect and Unite for Black men who have sex with men. Currently, he leads, I think, one of many NIH studies assessing the feasibility of organizational partnerships for healthy living in healthcare organizations serving people living with HIV. As the director of the Implementation Science Research Lab, Professor Martinez conducts high-impact health disparities research and also trains the next generation of biobehavioral researchers. So we are very excited to have you here.
Excellent, thank you. Thank you so much for that introduction. I have big shoes to fill after that JD presentation. So I'm gonna try to power it through. It's not gonna be as fun as Sarah's presentation, full disclosure, but here we are. Here's the outline for today's talk. First, I'm gonna provide some data, the latest data on disparities impacting sexual and gender minority populations, in particular regards to HIV and mental health, including the latest CDC data that points to an increase of new HIV infections among gay and bisexual Latino men. Then I'm gonna go over EIS. We had great presentations by Dr. Rabin and Dr. Smith, so that's gonna be a smooth. Go over REAIM, CIFR. Also have a discussion about the latest advances on implementation science and pushing for equity. Leopoldo Cavazza, I'm gonna bring in some of these articles here that have been pushing about that equity component in implementation science. And then we're gonna dive into actual projects. We're gonna go over 4 NIH-funded trials on medical legal partnerships that we're leading as a team, all of them guided by REAIM and CIFR. 2 of them are hybrid type 2 effectiveness trials, so we're gonna be able to see some of that and how that works out. And I was able to sell that to NIH. After JD's talk, I questioned it, but this is what we sold and got funded. Then I'm gonna go over 1R01 studies, an efficacy trial on couples-based intervention for Latino male couples, and then wrap it up with some initiative that I'm doing on AI and knowledge graphs that my component within these trials are more about community engagement and dissemination, which are essential in implementation science. And then gonna wrap it up with a future direction and some points to think this forward. I wanted to start with a positionality statement. As a gay Latino immigrant, my research is profoundly impacted and informed by my own experience, lived experience, navigating intersecting identities and systematic inequities, right? This perspective shapes my approach to equitable implementation science, ensuring that my work is deeply rooted in the reality of systematically and structurally excluded population. I also understand the importance of maintaining objectivity in that research, and my research is informed by systematic engagement of communities, right? Integrating community advisory board and scientific advisory boards in all the stages of the research project. So you're gonna be able to see some of that in some of these research projects, and also engagement with a wide range of stakeholders, right? Thinking beyond community-based organization and engaging for-profit organizations. For the couples trial, we're working with Boombox. It's a large for-profit marketing company that is actually developing this online intervention for Latinx male couples. We're also working with Bill Clinical. I think you're familiar with Bill Clinical. They're in charge of recruitment. They have a big platform for recruitment, and they work with a lot of NIH-funded trials. So here is the data that, folks have been pushing for so long. Vincent Ramos since 2017, and people were not caught on attention. Well, he actually wrote this paper, The Invisible HIV Epidemic and Crisis, kind of raising the alarms. And now the latest data from the CDC proof saw, right? We have Latinos had the highest proportion of new HIV diagnosis among gay and bisexual men in 2022. Latinos represent 19% of the US population, but accounted for 33% of the new HIV infections. So we saw a decrease among all groups and subcategories, but we saw an increase, drastic increase of new HIV infections among gay and bisexual Latino men. There is a short clip that brings that and really highlights some of those systematic and structural drivers of the HIV epidemic among Latinos. And I think we do have a little bit of time, so I'm going to play this 4 minutes clip that was just published, by the way. Yeah. So this particular video was just really released a couple of days ago. Um, let's stop it here. And let's bring it back.
Zoom again quickly.
So I really like this video because it really documents the real challenges and why do we have a crisis, right? Access to care, culturally and linguistically appropriate care services, healthcare deserts, right? Where you see and map them out within this 50 jurisdictions. But also, here's some data, latest data for transgender populations. And a new CDC, well, it's a couple of years ago, CDC issued brief that look at data for transgender women. 62% of Black transgender women and 35% of Latina trans women surveyed had HIV, compared to 17% of the white counterparts. So you see a stark disparities also with gay Latinos and also bisexual Latinos and also Black and brown trans communities. Regarding mental health, the latest surveys from the Trevor Project also point at really critical health disparities and mental health disparities impacting LGBT population. 2/3 of LGBT people reporting needing mental health services. However, only about half of those LGBT people with reported need sought and received care. So we also see a similar tier of critical health disparities on mental health as well. So now we're going to dive into the implementation science. And I think we have seen some of these articles. Implementation science is an integrated concept that links research and practice to accelerate the development and delivery of public health approaches and intervention. It looks at equity, efficiency, scale up, sustainability of programs, policies, and practices. There are 4 core objectives, right? Also within implementation science, informing policy design and implementation, that idea of assessments, improving people's health, strengthening healthcare service delivery, and empowering communities and beneficiaries. The last one, we're going to see a tell here in some of our work, how we worked with communities, building and rebuilding that empowerment through dissemination. There's a growing call, and this is the articles by Leopoldo Cavazza, of reframing elements of implementation science to address inequities. Highly recommended. Bauman and Leopoldo Cavazza focus on the reach from the very beginning, right? Design and select intervention for vulnerable population with implementation in mind. Implement what actually works and develop implementation strategies that can help reduce inequities. So thinking about inequities, develop the science of rapid adaptation and rapid qualitative analysis within implementation science, and use equity lens for implementation outcomes. Robin did a great job today also talking about the health equity implementation frameworks, right? And it integrates 3 health equity domains, right, that are critical, right? Cultural relevant factors of the recipient, thinking about the target population, thinking about the demographics of that population, that clinical encounter, right? That patient-provider interaction is essential, and looking at those characteristics of those providers and those recipients, and the societal context, looking at policies, right, that have diminished the impact or the delivery of that intervention. There's also implementation mapping, intervention mapping. We have talked a lot about that. Here are 2 articles that we actually use intervention mapping. One, to adapt an intervention for sexual health, related to sexual health among Colombian youth in Colombia. And the other one is adapting an intervention for behaviorally bisexual and heterosexual Latino men in the Midwest, in Indianapolis, Indiana. Here's some of the elements, core elements of intervention mapping: conduct and implementation needs assessment, identify implementation outcomes and objectives, choose that theoretical framework and produce implementation protocols and materials, and of course that evaluation component that must be ongoing throughout. So these are 2 examples where we integrated and implemented intervention mapping to adapt and implement an intervention. Here's an overview. You have seen this slide on REAIM, reach, effectiveness, adoption, implementation, and maintenance. We use a lot, and the 4 trials that I'm going to walk you through are guided by REAIM framework, the one on medical legal partnerships. So we're going to go into detail on that. There's the EPIS framework. We cover a lot on that today as well. There's the CIFR framework, looking at either inner setting, looking at the outer setting, another one that I use a lot in my research. And there's also the types of hybrids. JD covered this extensively today. And most of the research, all the trials that we're going to be discussing today are on the hybrid type 2. And even, even JD's presentation, I question, right? Do we need 5 years for each of those hybrids? Do we need 5 years for hybrid type 2, 5 years for hybrid type 3, 5 years for hybrid type 3? So even that, even thinking about how can we perhaps start thinking about combining hybrid type 2 and hybrid type 3 to really test the effectiveness of the interventions. So now I'm going to walk you a little bit about our studies, our 4 studies of medical legal partnerships. And it all started back in law school when I was doing my internship at the Migrant Farm Worker Law Center in Indianapolis, Indiana. And this is some of the work that we have done and documenting some of these disparities. It wasn't about putting on a condom, right? But it was about the social and structural drivers that were driving the HIV epidemic among Latinos in Indianapolis, Indiana. Here's some of the voices. Many people won't go and seek out services because they're afraid it will affect their immigration status. For fear of being found out as undocumented immigrants, they don't do seek help. For trans populations, right? As trans individuals, we're constantly challenged by discrimination, stigma, violence, homelessness, and lack of comprehensive trans care. Support is needed to navigate through legal and medical systems, like name change and access to hormone affirming surgery. So once again, it's not only about behaviors, about intervening in the systems and really addressing some of the social and structural barriers to care. That's how my projects on MLPs all started back, once again, in grad school. I'm going to provide some definition. We're going to be using a lot of health harming legal needs. So what is a health harming legal need? Health harming legal need is a conflict between individual and government or private entity or a deprivation of a civil or legal right that directly or indirectly affects a person's access to or retention in care. So it's pretty much the social structural conditions that impact a person's access to care. And we're gonna walk through some of these screenings that we have developed to identify some of these health harming legal needs. What are MLPs? And here's some of our work on MLPs. MLPs offer structural integrated intervention that could address health harming legal needs and facilitate improvement in medical and psychosocial outcomes among systematically and structurally excluded population. Through legal, that legal intervention, MLPs can ensure that patients are able to access comprehensive services in a culturally sensitive environment. So all of these 4 trials, what we're testing is a critical component, access to and the intervention of the legal aid intervention, having that access to the attorney and the attorney intervening on site, right after that patient screens for health harming legal needs. Our research on MLPs document the importance of identifying the level of severity early on in that patient engagement process, So having comprehensive screeners to identify the health harming legal need early on before eviction, So coming up with questions to identify housing instability is critical in that point of engagement. Initiating action to resolve legal issues early on, So it's not only identifying, It's providing that direct linkage to the attorney on site. So all of these trials, what we're testing is the presence of the attorney on site. So it's the identification of health harming legal needs and rapid linkage to the attorney right after that person is screened for health harming legal needs. Also, coordination of medical and social and legal providers, Creating, establishing comprehensive MOUs, memorandum of understanding for that patient sharing of information between the legal provider and the social and medical providers. We have also identified 4 core components of medical legal partnerships. Support of that leadership, You need that champion leader, executive director to really buy the idea of bringing in a lawyer that could cause all issues in your team and work with medical providers. So you need that visionary executive director within that nonprofit organization to buy the model. You need that provider patient trust already embedded in that healthcare team, Readiness is important for MLPs. The physical presence of the attorney. So there are several models of MLPs. from referral to legal aid, to working with a legal law clinic, right, to doing that warm handoff. But then the essence of MLPs is having the presence of the attorney on site. So that's is critical. And of course, reliable funding streams, right? Attorneys are expensive, right? The trial that we're about to launch next week at Hope and Help, funded by the SHORM, the attorney was $96,000, right, for a year. So attorneys are expensive, right? And working with these legal public interest law groups are expensive. So that's something to consider when you're launching an MLP trial. Now, this is a paper that we just published too, looking at for timely legal care for people living with HIV. What is needed, right? What are the essential components of these medical legal partnerships? Formal agreement between medical and legal partners, right? Having those MOUs with clear duties and responsibilities for each of the partners. Focus on a specific population. And while you're gonna see all of these 4 funded studies of medical legal partnership, we have a specific target population where there's trans youth, immigrants, people living with HIV, or formerly incarcerated individuals, right? Clear outcomes that we're looking at. Strategic legal needs screening for patients, right? For all of these trials, right, we go in with an initial screening for health harming legal needs, but it needs to be adapted. The legal needs impacting formerly incarcerated individuals may be different, than those impacting trans youth, for example. So before we go in, we engage a community advisory board and a scientific advisory board to refine these screening instruments, right? Tailored to the unique health harming legal needs of these different populations. Legal training for healthcare team and the legal team. So we, in each of this trial, we put together comprehensive MLP trainings, right? Lawyers are not aware of the HIV care continuum at all, right? So you need this comprehensive training for MLP provider. Information sharing, right? There's 2 pieces of information that happen, right? We researchers are collecting data from attorneys, from the healthcare partners, from the study participants, right? But then we're also looking at information sharing between the legal provider for a VAWA case, for example, abuse, visa mechanism, victim of violence, between the lawyer and the social worker, a medical healthcare provider. So these are essentials, right? Having clear established protocols for information sharing among all these partners involved. Client provider trust, and of course, diversity, cultural competence, and that compassion, right? That idea of the champion lawyer, right? That compassionate social worker. Omar, I don't buy it, right? And this is actually something that we had to sell to NIH in our first MLP R21 funded trial, right? What is the difference between a case manager and social worker, a lawyer? Why do we need a lawyer as part of the healthcare team, right? Why not a case manager or social worker? So here the added value of the attorney, looking at patient-facing legal support, right? Legal partners can address health harming legal needs. They can prevent issues from becoming legal needs, right? The whole idea of preventive legal aid and know your right workshops, which we're gonna go over in some of our tires. Provide guidance to clinical staff during the course of that patient care, right? For a U visa mechanism, right? The lawyer needs to be working with the social worker for that letter, right? The provision of that letter. So you need that. The lawyers can provide guidance to that clinical staff. And the whole idea of preventive legal aid, right? The know your rights workshops. The first study that we're gonna go over, guided by REAIM and SIFR, is testing this model of care for people living with HIV in Philadelphia, Pennsylvania. So it's a feasibility and acceptability trial. We know that unstable, insecure housing is closely intertwined with the HIV epidemic in the United States. There's also issues of adherence to medication and serious viral suppression, guided by all this intersecting structures and systems, discrimination, structural stigma, food insecurity. So it's out of that focus on the need to address on those upstream factors that led to the writing of this R34 in Philadelphia, Pennsylvania. So aim 1, it was all about refinement of this intervention and the training for providers, right? We put together comprehensive training that we're gonna go over it later on. Aim 2, testing the feasibility and acceptability through REAIM and SIFR. And back then, we added an exploratory aim on looking at COVID-19 and how that impacted and intersected with the HIV care continuum. Of course, we had to do the logic models, right? And for that trial, looking at mission of the organization, looking at the organizational characteristics prior to launching the trial, right? we had two side organizations that needed to be matched based on the characteristics, right? So we needed to look at the mission, the patient population we serve, the characteristics of the providers embedded at these two clinics, that they were similar, that they could be matched. So the agencies were matched, and then they were randomized to either MLP, medical legal partnership, attorney on site, or referral to legal aid. In some of our work, prior work, right, and I included it here, the R21, we found out the presence of 3 continuums of care, right, within these MLPs in the country. So there's the HIV care continuum, but then there's also the legal continuum of care, from identifying those legal needs to intervening and engaging that patient, that legal engagement process. And then there's also the social service continuum of care. So we wrote an article on describing these continuums of cares within these MLP settings that was happening already organically. Logic models, we have talked about it. It's not as pretty as the ones we have seen here, but this is the one we put together: inputs, intervention activities, level and linkage outcomes, and then those outcomes looking at short terms and long-term outcomes for the MLP. Training, Omar, it's finally here, right? So here's the overview. This was a 2-day training for medical and legal providers. We had a section about differentiating between social determinants of health and health harming legal needs, the difference between those two, and the focus on the health harming legal needs. What is public interest law, right? So we walked through the health providers about that public interest law, the HIV care continuums, effective ways to screen for health harming legal needs. So we had a session about that, integrating legal services and healthcare services, best practices for screening, data collection and analysis, and any other supplement materials that we include as part of that training. Here's the end product for the screening for Philly, right? You're gonna see the difference. There's gonna be differentiation of the screening. This is the screening that we currently have at the trial in Philadelphia, the R34 trial. On the left, you have more of these social needs, but on the right, you have more of these legal needs, right? Separation, divorce, immigration, social security benefit, custody, right? Other benefits, personal planning, right? Writing a will, and then other. It's important to understand also that prior to the implementation of this screening, the case manager, Sandy, a champion case manager, is trained to really ask follow-up questions related to custody, related to divorce. So this is not the only thing that the patient is getting, right? The case manager walks through the screening with the patient to really identify those health harming legal needs. What's on the ground? We have 3 case managers, social workers, 2 at TPAC and 1 at the control site condition. We have attorney on site 1 day a week at TPAC, Thursdays on Friday, depending on the week. The attorney performs an approximately 30 minutes intakes and gives legal advice. And then we also have ongoing legal clinics, know your right workshops embedded as part of that trial as well. And then we have assessments, baseline, 3 and 6 month follow-up for patient population, but we're also capturing data from providers, right? A baseline 3 and 6 month follow-up. We're also collecting attorney case summaries, right? Thinking about function and formats, right? Here is the attorney completes these for each patient that they engage, right? Presenting needs at that time of the screening, issues addressed by the legal clinic for the disabled, attorney on site, the case summary, the outcome resolution, and outstanding issues, right? Issues that were not addressed by the attorney and were referred to other legal generalists for care. So we're capturing, this is de-identify, an example of this, one of these case summaries, right? Andrew Mott is the attorney. Up to date, we're proud to say this is actually dated. We're close to 190 participants engaged in the trial. Here are some of the top health harming legal needs being seen by the attorney in Philadelphia: advanced planning, landlord-tenant disputes, domestic violence, legal name change. We have seen over 20 men and women of trans experience as part of this legal clinic. So we have case summaries for those legal name change as well. And we have that engagement in service, the legal clinics, and ongoing provider education and training. Omar, I don't buy it. This is not true. Here's a snapshot of the actual PowerPoints that actually happened with Andrew Mod. We had a session on tenant rights and housing issues. Philadelphia is seeing, like any other major cities, a housing crisis impacting folks living with HIV. So we had a really good session on tenant rights and housing issues impacting Philadelphians. We had the legal name change. We have two clinics actually now on legal name change. TPAC, family law overview, and the whole idea of advanced planning and writing wills and so forth. That's the next step. We're going to be done with data collection, fingers crossed, within a month, including follow-ups, fingers crossed. And then the R1 effectiveness trials is thinking about the next step for this R34. The second one, funded by the SHARM initiative. This is something that we're really proud of. And I'm going to walk you through the progress up to date. Fingers crossed. We're planning to launch this week, but it was pushed back for next week. But we're going to be in the field anytime shortly. You know, even thinking about conceptualizing this project for formerly incarcerated individuals living with HIV is stepping back and looking at incarceration of Black, Brown, and Indigenous communities throughout history, right? And looking at the systematic employment of incarceration for marginalization of Black and Brown folks in this country. Studies have documented the barriers to HIV care post-release, including lack of medical insurance, mental health, emotional difficulties, perceived conflict between substance use and medication adherence, and poor engagement and retention in HIV care. Further exacerbating these problems are the pervasive impact of intersecting forms of stigma. My work on intersectionality, highly recommend Lisa Bullock's training on intersectionality. That really transformed my work, and big kudos to Dr. Bullock's. For formerly incarcerated individuals, you're looking at stigma, oppression, structural racism and discrimination, legal financial obligations, right? Fines and restitutions, driver license restatement, right? So some of the health harming legal needs impacting formerly incarcerated individuals. Expungement and reconciliations are some of the barriers to care impacting formerly incarcerated individuals living with HIV. Here are the aims. We're done with aim 1, refining the protocols assessment and conducting the training at Hope and Help with both health and legal providers. And then aim 2 is looking at feasibility and acceptability. And then we're using REAIM and CEPHR to really assess the impact of the intervention. Progress to date, what we have done up to date with this trial, legal and health partners were identified, and now we have finalized both the MOUs and service agreements for Hope and Health and Community Legal Service of Orlando. So those are the key partners. Some of the domains that patient is assessment, we have social demographic, criminal justice involvement, documentation status, mental health, HIV care continuum, looking at the whole continuum of care, drug and alcohol use, discrimination, experience of discrimination with Nancy Krieger experience of discrimination instrument. We ask questions about the legal landscape of Florida. So we have some questions related about how the policy landscape, right, has impacted access to care. We ask about comorbidities, resilience, and provider satisfaction. We're capturing that patient interaction with both the lawyer and the healthcare providers, looking at communication and satisfaction. We also conducted the training and developed assessment for providers guided by REAIM and CEPHR. So we look at each of those constructs and all the questions that we ask providers, right, are responsive to some of these REAIM and CEPHR constructs. And then we had a scientific advisory board meeting conducted already. 4 attorneys were part of it. One of the attorneys was someone with a history of incarceration, 7 academics, and they provided feedback to the training, to the assessment, and the training and the assessment and the screening for health harming legal needs. We're done with the training. It was a success. We had over 15 providers and attorneys being part of the training. Catherine Nawalny was part of the training. Dr. Prado was part of the training. Willie Suarez, an amazing champion psychologist, was part of the training. He covered the area of mental and physical health or formerly Eddie Suarez. Yeah, Eddie. Okay, Eddie Suarez. Steve Safran is correcting me here. He's just amazing. I love Eddie Suarez. So here's some of the feedback from the training, right? Providing a new service which which will hopefully increase patients' linkage to care and other patient assistance programs. Patient clients having the ability to make informed decisions by knowing their legal rights, resulting in improved outcomes in all aspects of their health, including health. Fingers crossed next year, we're gonna have some feasibility and acceptability data. I'll be ready for that R1 effectiveness trial. So that's that. Second, the third MLP trial, guided by Reaim and Cipher and Health Equity Framework, is part of the ATN network. I'm the MLP lead on medical legal partnership. We're rolling out this multi-level intervention that includes economic, legal, and behavioral across 7 sites in the country. And once again, with the legal piece, we're doing a screening for health harming legal needs and then linkage to the lawyer side. We know that transgender and gender diverse youth are burdened by HIV. We also know that trans youth, including parents of trans youth, are impacted by a unique set of health harming legal needs, legal, social, and medical information issues with gender affirming care. So we're integrating legal aid in all of these 7 clinics and 7 sites across the country. And once again, we're testing this multi-level intervention, legal, economic empowerment, and behavioral interventions. Here's more about the specific aims, how we structure it, right? To test the effectiveness of this status neutral intervention, multi-level intervention, then looking at the heterogeneity of treatment effects, looking at HIV status, gender, site characteristics, and readiness, and then looking at prospective implementation process, evaluating using the health equity implementation framework, consult CIFR, and we're also doing Reaim for this trial. Here's a walkthrough of the intervention. On the left, you have the conceptual model. We have the 3 pieces of intervention that we're testing: affirming peer HIV support, legal support, and economic empowerment. We're looking at mediator, increasing gender information, increasing social support, decreasing health harming legal needs, increasing that economic stability, financial self-efficacy, and future orientation. And then the primary outcome is HIV prevention and care continuity. The status neutral intervention, where we're engaging both HIV negative and HIV positive youth. Here's a walkthrough. The intervention is a 10 weeks intervention that includes one-on-one and peer support and legal aid and a mentor for that economic empowerment. Here are some of the sites that we're intervening. Calendar, one of my favorites in New York City, leading gender affirming care in the country. That's going to be one of the sites for the trial. Friendway as well, the Children's National Hospital in DC. We're also doing it in Tulane with Manny there. St. Jude's Children's Research Hospital in Memphis, Tennessee, looking at implementation science and intervention delivery and looking at the setting, right? Tennessee having one of these craziest laws and policies targeting trans youth. So we're going to be looking at that as well and being the intervention tested there. You know, in the process of the trial, looking at implementation science, right? And thinking prior to implementations, here are some of the topics that we have covered as a team, looking at anti-trans legislation and how that impacts gender affirming care for youth, for parents, looking at health harming legal needs and being really mindful of having comprehensive screening for health harming legal needs, taking this screening 5 times to the Youth Advisory Board for feedback 5 times, right? So even thinking about that process and also data safety and management and ideas for process evaluation. That's done. The 4th MLP trial, R1, is a multi-site R1 trial with immigrants in FQACs serving migrant communities in San Juan, Puerto Rico, Philadelphia, and New York City. It's a hybrid type 2 effectiveness trial. Once again, testing this MLP model with migrant communities in FQACs in these 3 sites. Here's some of the data that you're familiar with, right? Intersecting epidemics such as cardiovascular disease and other disorders have tested the limits of healthcare systems serving migrant communities. The early detection and severity of those conditions are aggravated by systematic barriers to primary care, and providing legal services is essential, right, for migrant health. So we're testing this MLP model. Aim 1, patient outcomes. That's how we frame it. Aim 2, looking at implementation outcomes of these MLP trials in these FQACs in these 3 cities. Re-aim, CIFR are guiding this. And then we have an aim 3 looking at sustainability strategies, right? How we sustain these models of care in low resource settings in FQAC serving migrant communities. So thinking about that and dissemination strategies. Core components of these trials. Number 1 is training and capacity building. We just had a big 3 sites training conducted in San Juan, Puerto Rico, where we trained all the healthcare and legal partners for the trial, similar to what you have seen: public interest law, HIV care, comorbidities, what is public interest law, best strategies for screening for health harming legal needs. And then we're also doing direct services. So we're embedding legal aid at these FQACs in San Juan, Philly, and New York City. The training is a comprehensive training on screening, on capacity building, on ways to assess the effect of the intervention, on direct core component number 2, direct legal services. Once again, we're gonna have an on-site attorney 2 days a week in one of these FQACs. We're gonna be tracking legal aid through those attorney case summaries that we have developed for these trials. And then we're gonna be working on MOUs and how to better information sharing between the research team and the health and legal partners. We're also gonna have monthly in-service Know Your Right workshops in each of these jurisdictions. We're gonna have Know Your Rights federal law, right, immigration, but then we're gonna have Know Your Rights workshops specific to those jurisdictions. Feminicidio is a big issue in the island of Puerto Rico, especially for trans women. So we're gonna have some targeted Know Your Right workshop for each of these jurisdictions based on those unique health harming legal needs. In Philly, we're gonna continue those housing and tenant Know Your Rights workshops. Here is something that, once again, it took a year, right, to get this up and running with legal partners, with healthcare partners. We have identified already all the sites, all the legal and health partners. We're also working with the National Center for Medical Legal Partnerships, so they're providing guidance as well on assessments and measures. Bethany Hamilton at the National Center for Medical Legal Partnerships. Samantha Morton, she's a national recognized expert on MLPs. And we also have a national, across all the sites, Community Advisory Board and Scientific Advisory Board. As part of this trial, we have a comprehensive, working with a for-profit organization, a for-profit, an interactive online platform for each of the sites to have access to, including the Know Your Right workshop. So if you're in San Juan, Puerto Rico, and want to be part of a Know Your Right workshop in Philadelphia, Pennsylvania, you can join through this interactive, where all the sites will have access to this interactive platform for dissemination and coordination of all the trial, of all the sites of the trial. Jonathan Menendez, he's amazing and has a company, a marketing company that is helping out with that. The last project, not funded, currently working on, but we're looking at implementation science. This one is going to be Sugel Malaver Rivera, Carlos Rodriguez Diaz, and myself. We're putting the grant within the next month. So it's testing this MLP medical legal partnership trial with sexual and gender minorities across the island of Puerto Rico. We're going to be doing a stepwise design, selecting 3 clinics, and all the 3 clinics at some point are going to have the attorney on site. Once again, targeting SGM population. The UG3 phase, this is an interesting mechanism. It's a 7 years grant. The first UG3 phase is a 2 years, similar to the R21, that format it worked. And then the other 5 years are the implementation of the trial, right? Effectiveness trial, the UH3 phase. So aim 1 is just preparation, right? We're working on that training, we're doing the training, and then aim 2, 3, and 4, right? We're looking at patient level outcomes, implementation outcomes, and sustainability strategies as well. This is a work in progress. We're getting it fresh. Kudos to Suhel and Eda who worked on it. We're all worked on it, but they really put it together. So we're integrating, right, CIFR and REAIM as part of those aim 2, 3, and 4. But we're also, for the first time, Carlos Rodriguez Diaz came up with this community resistant framework that was published at AJPH last year. And we're integrating that framework to test the effectiveness of the implementation. This framework is so unique because it has that, it takes into consideration that Puerto Rico as a colony. And what does it mean to be doing health disparities research in a colony, in an FQAC that is part of a colony, right? So highly recommended to read this community resistant framework that Carlos Rodriguez coined, and that's going to be guiding aim 2 to aim 4, right? So here's how for HAB, right, you can push to have more than 2 frameworks in your specific aims, right? CIFR and REAIM looking more at that effectiveness, and then the community resistant framework more guiding that dissemination and understanding of doing research once again in a colony. So kudos to Carlos, Suhel, and Eda for putting this framework together. Now we're done with MLPs, medical legal partnerships, REAIM and CIFR, and resistant framework. And now we're going to go on this efficacy trial, couples-based HIV prevention intervention, status neutral. We have 12 minutes, so we're good. This is an R1. We're testing the efficacy of the intervention. We're looking at mediators and moderators, and then we're also looking at that practical guidance for sustainability and scaling up. So we have that community engagement embedded in aim 3, community advisory board and community forums every year. We're working with the Latino Commission on AIDS to really guide that aim 3. So everything that we're learning from the trial gets feedback to the Latino Commission on AIDS, and every year they're going to be hosting a symposium to share back data from what we're collecting in the trial. So it's that ongoing, right, dissemination process working with the Latino Commission on AIDS. Before we got here, there was a pilot, proof of concept, feasibility, and acceptability. Here's the snapshot of the pilot findings. You got to publish that. The first initial submission of the R1, the reviewers did us for not having the pilot trial findings published, right? So important to really be publishing before you go into that efficacy or effectiveness trials. So here's more about the snapshot. We engaged 23 couples. We successfully screened and recruited couples through online platform. We have over 10,000 Latinx male folks engaged in our Twitter, Instagram, and social media accounts. And because it was a small pilot, we didn't find any significant difference in that outcome, HIV protected outcome. But however, we saw a significant increase in relationship functioning among couples in the intervention groups relative to that control. Here's now what we have going on for the efficacy trials. We work with Bill Clinical. They develop all these recruitment strategies. One of the things I've learned, including the importance of engaging a community advisory board, when I first started doing this work, the whole idea of sex sells, right? And if you look at all the PrEP HIV studies with gay and bisexual, shirtless guy. And the CAB, all my CABs actually have been against the idea of really pushing against the hypersexualization of Black and brown bodies in research, right? So if you look at my trials and in my research, always clothed folks, right? And really representing the beauty, diversity of Latinx male couples, right? Capturing that, whether it's age, whether it's family dynamics, right? Stressing the importance of community. The CAP really informed these flyers. It's a community-based HIV prevention study. So the community is driving this study. So here's the end product. Sorry, we had to edit. It's 315. We increased that recruitment incentive. Another important critical component, paying participants, right? Always budget, right? For this one, it's $50 per session. For assessment, it's $55, $60, and $70. So always pay your study participants for their time. And I think that that's one of the key successes of our recruitment strategies, including CAP board members. Each CAP members get paid $100 per CAP meeting. So pay your study participant in CAP. We have done 3 CAP meetings up to date, including CAP meeting with English speaking and monolingual Spanish speaking community advisory board members. Once again, they have helped inform every single thing of this process, of this project, from assessment to recruitment materials, to intervention activities and exercises. Here's a little bit more about the snapshot of some of our activities of that engagement. You know, social media is key for recruitment and engagement. We're working with Bill Clinical. Here's some of the relevant feedback that we have already received from CAP members about the significance of this study, right? Understanding the importance of Latino male couples to a stronger, healthy relationship within our communities, and the importance of study. The importance of the study lies in its potential to drive positive change, that community change. Here's a snapshot of intervention activities, right? So the guy logs in into this online platform and walks through intervention activities and exercises. There's role plays, there's case studies and scenarios responsive to the needs of Latinx male couples, right? So we're working with Boombox to develop the online platform, but we're also working with Descolonizarte Teatro, is a grassroots theater group in Orlando, Florida, to really develop all the intervention materials. So all the role plays, all the activities are going to be narrated by a queer Latinx person, and also the representation of the role plays and the couples are going to be Latinx folks. Done with the couples trial, we're going to wrap it up with artificial intelligence and knowledge graph and community engagement on that. This is a project that is funded by NSF. I'm a consultant co-investigator. We're building a knowledge graph to provide a comprehensive understanding of the social, economic, and political factors that contribute to homelessness, and triage existing services and resources to support people who are unhoused individuals in Philadelphia. We have a paper that was just accepted pending minor revisions, where we describe the process of engaging a community advisory board and building this knowledge graph to identify some of the social needs impacting unhoused individuals. We present here some of the data from the community advisory board. So this is a perfect example that there's room for community engagement in AI, in artificial intelligence, knowledge graph research, right, where we integrated a community advisory board to guide all the stages of the development of this knowledge graph NSF-funded study. The second one is a project that I'm a consultant. We're developing responsive AI to predict diabetes. We had a community advisory board just recently as well, so I'm engaged in that community engagement component that is helping form this development of this AI predictive modeling. The other one that is now pending review is this new NIH initiative. This proposal aims to develop innovative technologies to evaluate high-risk inaccuracy for medical advice provided by large language model, right? The whole idea of hallucination and omission in these chatbots, GPT. So folks are going into ChatGPT, but entering answer, right, clinical questions, and we're addressing through AI hallucination and omission in those answers, feeding back to study participants and providers. So throughout the project, I know it's tiny, we have a stakeholder engagement, right? Even for AIM-1, for all the stages of the research process, we're integrating CAB, we're doing focus groups, in-depth interviews, Delphi panels integrated across all the aims of the study. Last but not least is this training grant guided by REAIM. It's not a research grant, but yes, you can use implementation science to evaluate training. It doesn't have to be research. Here's the table that I put together, right, as part of the implementation person of this training grant. We're looking at reach, effectiveness, adoption, implementation, maintenance of that training initiative, the questions that we're asking, the measures, and the data collection methods within that table. Future direction, to wrap it up, we need to be thinking regarding implementation strategies, do more effectiveness research, harness implementation science to promote health equity, increase the economic evaluation. JD really touched upon this. We need to be thinking about doing more cost-benefit analysis of these multi-level structural interventions. So thinking about that and evaluation of that. Leverage implementation science to address health disparities in biomedical prevention and treatment research, thinking about cancer, Alzheimer's, diabetes, moving this line of research forward in other health conditions as well. Lisa's Buleg, one of my mentors, once again, the intersectionality training, highly recommended. It's a life-changing experience as a senior investigator or early stage investigator or mid-career investigators. Really thinking about the upstream factors. We have failed in HIV for the past 40 plus years, right? Focusing on putting on the common. Shit ain't work, right? Let's think about the social and structural drivers of the epidemic. Housing instability, food insecurity, right? Legal aid and thinking about structural interventions, policy interventions to really address the disparities impacting underserved and marginalized communities. On MLPs, right, we need to be thinking about better screenings and referral systems, the level of legal aid, right, the dose of legal aid and really capturing that dose. Is it more preventive legal aid versus an actual legal intervention occurring and really capturing the impact of that dose, right? And looking at patient outcomes, the value reduced, the value of benefits obtained for the patient, looking at more of that, those economic evaluations of medical legal partnerships. Here's an area, here's on MLPs, all of these projects, all of these trials focus on patient-facing legal support, right? So we're testing that. Samantha Morton and myself, we're pushing for other forms of evaluations, right? So looking at that idea of team-facing legal support. So it's not only a attorney providing legal services to those patients, but it's really changing the practice within that clinic, right? And informing providers. So looking at capacity building for staff, right? High dose orientation and training. What's the impact, right, of that team-facing legal support? The attorney providing training to the attorney, to the medical doctor, clinician, social worker, case managers. So looking at those more practice-aligned learning strategies and really testing this team-facing legal support. I think you have seen this, and when I read it, when I saw it, the revised NIH Office of AIDS Research Strategies was presented in Los Angeles. There's room for implementation science from goal 3 to goal 4. So I think that there is still hope and room for implementation science. Status neutral approaches, right? Let's move away from this negative and positive, right? Let's look for status neutral interventions for interventions. Also thinking about locally homegrown developed interventions. So let's continue to leverage on those model photo boys, peer-led approaches. So let's continue to invest on that. Mentoring and supporting the next generation of biobehavioral researchers. I'm a CDC Mary grantee, round 4, and that really changed my life. CDC is similar to the K Award training mechanism. It's very targeted towards underrepresented minorities to research. Madeline and I just published a paper on the impact of this CDC Mary. These are interventions led by 4 Black and brown folks in highly impacted community. And here we document the added value, right, of having underrepresented investigators leading that science. So let's continue to invest in the development and training of underrepresented investigators. I think that this is very clear. Also, it has been mentioned throughout the importance of community research collaborations and engaging community members and community partners in all the stages of the research projects. I want to acknowledge our study participants, study team, my mentors from Dr. Fernandez to Brian Dutch, and our research team, Ashley, French, Robin Davison, the list goes on. This work wouldn't be possible without them. And with that, I think I'm done. Thank you for doing. Okay.
Thank you so much for your very engaging presentation and your amazing work. Um, you talked a little bit about a scientific advisory board versus a community advisory board. Can you tell us how you were teasing out the different responsibilities?
Excellent question. So, for example, let's go for that R1 efficacy trial on couples-based intervention. The community advisory board is mainly of those with lived experience. So sexual minority Latinx men living with HIV, those impacted with lived experience. So we have some of that within that community advisory board. We have case managers, social workers as part of the community advisory board. The scientific advisory board in all of my studies are more providing that scientific guidance and consultation. So for example, Vincent Guillermo Ramos, the guy that you saw, the one that coined invisible HIV epidemic, he is part of the scientific advisory board for the couples project. So providing more of this consultation, guidance, that scientific design of the intervention, right?
So they're more methods.
Correct, correct. So that scientific advisory board, we have Vincent Guillermo Ramos, HIV epi, nurse practitioner. We also have Isa Fernandez. Dr. Fernandez is a psychologist with expertise, clinical developing interventions for Latinx male couples, providing guidance and that high-end scientific consultation and guidance to the study.
A follow-up question to that. You talked a little bit about your community advisory board. How do you handle like transportation costs, not unless it's like on Zoom?
Yeah, that's a great question. So all of our studies, all of our CAP meetings are done through Zoom now. The last CAP meeting I had in person was in New York City when I was doing my postdoc, right? So it's all through Zoom and they get paid $100 per hour. So that's the standard cost of that. But I also wanted to, when I write these proposals, you don't want to actually present this CAB, Community Advisory Board, and Scientific Advisory Board as distinct, right? Right in the way that they're talking with each other, right? Which is the truth, right? The feedback that you gave from the Scientific Advisory Board, what Vincent Guillermo is saying is at Emory, in his ivory tower, may not be actually what actually works in the community. So I take that feedback back to the Community Advisory Board, right? Is this applicable, right? Can this work to the community? So you need to write it in a way that they're talking to each other in that graphical and actually put it into practice. So it's describing their distinct roles, but it's also describing a process where they're in constant feedback with each other. And we researchers are the one sharing that information. So the feedback from the SAB, I always take it, always to the Community Advisory Board. We don't move forward without the CAB green light, and we're documenting all that process. So that's the next paper, talking about dissemination throughout, right? All the stages of the research process, documenting that process. And also we need to get ready for our first community forum led by Latino Commission on AIDS that are going to be sharing back all this data to the stakeholders. So we need to be documenting these findings. So we share back with them, and then they will share the nationwide through a community forum that they're going to be doing for us. I know, I'm barely making it here. You know, need coffee, right, all the time. Yeah, but to that point, and that's why I had that slide. I'm grateful to our team, right? It's a teamwork. Science is the teamwork. Isa was just texting me about the assessment for the right. So when I launched this trial, it's not only Omar, right? It's Isa Fernandez, it's Vincent, it's the CAB, right? So it's that teamwork that you put together. So everything doesn't fall on that PI. And I think that I have been effective, and I learned from my mentor, from Isa, from Brian Dodge, from Scott Rhodes, right? To that balance, right? And really putting that right team together to lead this project. It's not Omar's, trust me. Yeah.
But
some of these community engagement processes, because there's so much watering and tending and energy and effort and time.
Yeah.
for the supplements. And it's seen in all the materials and everything you do, and I'm curious, have some tools you really like. You have a law degree, so I feel like your MLU is tough.
Right on point, yeah.
But any tools you use or like think about?
Yeah, so practical things. So I think you have shared here, all my Zoom meetings gets that automatic thing transcript. And then I copy and paste it and take it to ChatGPT to further refine it. So talking about like using AI, so that's my process. So I have those files always after the Zoom meetings. I use a lot of matrices, right? Even when writing these papers, and major themes that have emerged from this community advisor board meeting, the knowledge graph, like NSF grant, right? I think that our project, they funded 10 hours, the only one with community engagement, right? Like literally. But look at the added value, right? These key players, what is, the rapid, the assessment of these social needs impacting on housing individuals, and that rapid feedback on that app that we're developing, getting that when there's a snowstorm, what shelters are going to be open, right? Direct, right? So the knowledge graph, I'm not an AI person, but it's going to be able to capture from Google and all these data sources, what shelter is going to be open, right? But that was the feedback of that community advisor board. Can this app in real time, depending on weather shit that happen daily, tell a person or house person right on time where to go for shelter because a snowstorm is coming tomorrow, right? Like this AI person would never thought of that, but the CAP did, and that informed that. Now we're capturing that, right? Snowstorms in Philly in real time, right? To really build a product that is functional and that actually works. So yeah, that community engagement is vital and essential in every part, even basic science research, right? AI, knowledge graph. Yeah, great question. Great question. So we have a combination, the one in Philly, full disclosure, the other ones were in the preparation stage. Only one, the one in Philly is now closing. We have 190-something participants. So it has been a combination of telelegal aid and in person, right? Because of those issues, right? Like initial challenges with transportation. I don't have a way to get to TPAC in Circuit City, and I'm in North Philly, right? Like, so we have embedded telelegal aid, and we're capturing that in an attorney case summary. The attorney saying like this legal intervention was provided over the phone versus in person. So it's a combination. We didn't like focus on just in person legal provision. So yeah, good point. You nailed it, right? So the R34, I had to use my startup funds, 40,000 for my startup funds, right? The R34, because attorneys are expensive, and what I like, the best model of MLPs is working with public interest law groups that have what we call legal generalists. That are the champion attorneys that can see from immigration to housing and tenants law disputes. So they're called legal generalists. Public interest law groups tend to be working with underserved communities. So you have these champion attorneys that know the area of the law, but also have a history of working with underserved communities. So within this partnership, so the logistic, right? So we partner with the public interest law group. We pay the part-time salary of that attorney, but we also need to pay for a space for that attorney to be housed at the health organization, right? All my trials are fully, like I'm mindful of that level of detail. The attorney is going to be there once a week. We need to pay the healthcare site for that space, right? So that is that. Then there's supervision. So all of my MLPs have a supervision line. So there's a supervision attorney working with that attorney, supervising attorney, to provide that guidance and support and help the attorney on those legal matters. The one employee, in addition to that, have a paralegal as well, right? So we decided to add that to support that attorney to deal, because it was a successful trial. We were able to improve it. You saw that, the numbers, but we didn't only serve those ones, well, now in the 190s, we're serving the entire patient population. So not only the people living with HIV are accessing the services, we're just tracking that data from those that missed the inclusion criteria, but they're serving the entire patient population. Because it will be unethical, right? That's another challenges with this NLPs. You come in with this distinct population, but these are real world clinics providing service to underserved communities. A person cannot come and say, you're not getting legal aid. It's only for, right? So those are the implications too of doing this research. So Andrew Maud saw the 190 something, but have seen plus patient population at TPAC that are not meeting our inclusion criteria. Someone not living with HIV but was evicted, right, on PrEP. So we've seen some of the patients there as well in TPAC were on PrEP. So yeah, it's costly for the SHARM, the trial, funded trial. Luckily, the team here was understanding of that, and thanks to Rosanna and Mohammed, right, we figured out a way to cover that 90 something for that attorney. That is an amazing, once again, talking about that, Black attorney, 20+ years of experience working at community legal services that is going to be embedded at that clinic at HoMBReS. So anyhow, yeah, it's expensive. For the R1, luckily we learn. So we have budgeted for the training for all these 3 sites. And the one that is come up now with going in for the SVM, the MLP with SVM in Puerto Rico, we're budgeting for paralegals as well. So we're budgeting attorney, paralegals, and supervision for these 3 sites that we're going to be rolling out the trial in Puerto Rico. Excellent question. I've been sweating like crazy. It's hot in here, right?
You're on fire, man. You're on
Yeah,
fire.
I'm always on fire. That's the issue. Take the shirt off, Steve. Oh, okay. You back there. That's a great question. And that's why we work with public interest law groups that have for sustainability purpose too, right? That the attorney is housed within a system with typically more than 20 public interest lawyers that even after the end of the study, because we cannot expect that all the legal issues are going to be resolved in 6 months, right? So we're just going to be collecting data up to 6 months, right? But that legal representation continues. And we cannot tell the patients, participant, bye Felicia, right? Like there's no way, right? So that's why these intervention trials are housed within public interest law groups. So there's that continuation of legal care past that intervention implementation timeline, right? So the attorney continues that legal representation past the 6 month. And no cost, right? Public interest law groups, is free legal aid. So we have to be mindful of that and strategic in that versus working with a law clinic that you just get the students during the fall and the spring, the summer, they're out. What happens at right? What happened at the community-based organization? So in that process, is thinking about continuity and sustainability of these models of care, which are great, right? Law clinics are great. Law student clinics are great, but they're not sustainable, right? Embedded in this model of care, right? Okay, one last question. Time is up. I'm getting the time is up. You go, Jaramillo.
I'm wondering how, speaking of this like sustainable model, how it could start pre-immigration with regards to then following the individual or supporting them or facilitating access to these legal experts and resources? Because I mean, hearing about your work in Colombia, hearing about your work in, Puerto Rico, and us being here in Miami and you also working in Orlando, how that could be facilitated in a way where it might look like a referral, or it might be, because it seems like it's so localized because also, I mean, no, the federal laws, but also the very nuanced city laws where people are in help, right? So if you know that these folks are potentially imigrando to
Yeah.
X city in the US and they come to you first in Puerto Rico, there's so much opportunity there.
Yeah.
And I wonder if that's something that you're seeing in the future, or if it's something that you think, I could do a postdoc
Yeah.
for,
Yeah.
no,
Yeah.
but
Yeah.
it's
Yeah. So-
actively as to how to expand that.
Yeah, so that's a great question. And all of these trials, right, have embedded, when we work with the public interest law groups, know your rights workshop, tailored to the specific needs of that population, in that particular city or jurisdiction. Legal name change, 2 legal clinics at TPAC, right? That was not what was originally proposed in the study, right? This consistent know your rights workshop have emerged as a result of the need and the focus on that preventive legal aid. With immigration, for example, we're already mapping out, because immigration is federal, so it will work across all this jurisdiction because it's federal. So we have embedded now visa mechanism. So you may not benefit from victim of violence now, but you're getting that preventive legal aid dose information that in case that you get impacted by violence, you can adjust your status through the visa mechanism. Or you can share that information with Pedrita and Juanita, who have been a victim of violence, right? So the whole idea of preventive legal aid and embedding Know Your Rights workshop as part of these trials. So it's not only the direct legal representation patient level, but it's systematizing these Know Your Rights workshops as we develop and test the impact of these MLP trials. That is not only legal aid, but there's the Know Your Right workshop focused on preventive legal aid. There's a training piece. There's a team-facing legal support that I think that there's a lot of areas there that we could tap on. Excellent question.
Thank you so much. And thank you to all of our amazing speakers today. This marks the end of day 1 of the EIS curriculum training program. Yay.